We'll change gears. I invite Dr. Sudheeran Kannoth. He is the rarest of the rare breeds in the Indian Academy of Neurology. I am interested in knowing as to how many of us are, neuroimmunologists. Dr. Sudheeran. In the Indian Academy of Neurology, how many of us are, having your qualification?
I am the only trained person.
Yeah, that's the rarest of the distinction that Dr. Sudheeran holds. We are very fortunate to have him on this platform. And a brief introduction. Dr. Sudheeran Kannoth is trained autoimmune neurologist. He has done a fellowship in autoimmune neurology from Mayo Clinic, Rochester, USA. This included the interpretation and reporting of neuronal antibody tests in the Mayo Clinic's neuroimmunology lab, as well as clinical care of the patient in the Mayo Clinic's autoimmune neurology clinic under the Department of Neurology. He has characterized and described the syndrome of autoimmune atypical Parkinsonism. I just bumped into one of your prescriptions and I didn't know that there something existed like an autoimmune Parkinsonism. He has developed the diagnostic criteria for intracranial infections, mycotic aneurysms. His areas of interest are, a huge list is here. I am interested in reading that. Immune-mediated peripheral and central nervous system disorders, autoimmune Parkinsonism, autoimmune ataxia, multisystem neurological disorders, myasthenia gravis, GBS, CIDP and other immune-mediated neuropathies, neuromyelitis optica, ADM, acute disseminated encephalomyelitis, paraneoplastic neurological syndromes, autoimmune encephalopathy and autoimmune dementia. So these are the areas of interest. So he will be talking to us on the evaluating neurological diseases with autoantibody, where and when, $1 million question. Dr. Sudheeran.
Thank you for the nice introduction, sir. Thank you, Chandra sir, for inviting me. So, actually, I will have a long introduction because if you straight away say when and where, it will be very boring. So, I will first talk about autoimmune neurology, which is my subspecialty. So, this is the term coined by Mayo Clinic. So, in US, neuroimmunology always means multiple sclerosis, and when they wanted to develop that non-multiple sclerosis arm, they coined it as autoimmune neurology. So only Mayo Clinic gave training for a regular fellowship program for that from 2006, and I am the fourth person to get trained in that. So all other neuroimmunology means MS and peripheral nervous system disease. So it is a newest branch of neurology subspecialty, and it is expanding spectrum. So day by day newer entities are created and newer antibodies are described. It intersects all the traditional subspecialties of neurology like movement disorder, epilepsy, behavior, neurology, because this is based on the etiology and others are based on the manifestation. And the last one is the so-called degenerative neurology. So that is very interesting, and that's what my focus is on. So this is Sean Pittock's slide. So you can see that autoimmune neurology disease can affect anything from brain all the way down to neuromuscular junction, peripheral nerve muscle, everywhere. So the manifestations are so much varied, and anything can be autoimmune. So, and not only neurologists, they can go to a gastroenterologist. Sometimes an NMO person can present with a vomiting intractable, they can go to a gastroenterologist. So all their investigation can be negative. They can develop a constipation or reflux-like symptom due to a gastrointestinal autonomic neuropathy. So all the investigation will be negative. They can go to a psychiatric if there is an autoimmune encephalitis or specifically NMD encephalitis, where they can have a psychiatric presentation. They can go to a urologist. Suppose they get bladder dysfunction, people assume that it could be prostate and all. Then they can go to an oncologist as paraneoplastic syndrome. They can go to cardiologist as syncopal episodes due to dysautonomia. Pulmonologists will see them with either type 2 respiratory failure due to neuromuscular weakness or lung malignancy with paraneoplastic syndrome. They can go to gynecologists also. NMDA receptor encephalitis, they can have an ovarian teratoma. Ophthalmologists with so many things like an NMO, MOG antibody. So the knowledge about this spectrum is very important. Though it was a new specialty, our first book came out last year. This is the Handbook of Neurology. Previously we used to call on Minkin and Bruin because they were the initial editors. So number 33 was released last year with the editors as Sean J. Pittock, who was my mentor, and Angela Vincent from Oxford. So now it has come official as an official specialty with their own book. So they can present with paraneoplastic, autoimmune encephalitis, NMO spectrum disorder, immune-mediated neuropathy. So many presentations are there. Just for namesake, I put this name. And just to show the clinical spectrum, without that, it will be quite boring. This is a hypothetical case. So this is a 65-year-old man who was a heavy smoker who presented with sensory symptoms, tingling and numbness of fingers and toes. There was ataxia, which was in fact sensory ataxia, no motor deficits. Nearly 6 weeks progression, but very severe. There was no diabetes. The patient had significant weight loss. Sensory conduction was abnormal. MRI brain was normal. X-ray showed a doubtful hilar node. All other workup was normal. And the investigation found that there is an ANA1 antibody positive. This is anti-neuronal nuclear antibody 1 positive. So it is a paraneoplastic syndrome. Related to the small cell carcinoma, which can present with sensory neuropathy. This is PM means paraneoplastic encephalomyelitis, where brain as well as spine can be involved. Limbic encephalitis, cortical and brainstem encephalitis. PCD is paraneoplastic cerebellar degeneration myelitis, autonomic dysfunction. This can be single or in combination. And this is an MRI of an ANA1 positive patients. So this is the way paraneoplastic can present with. So it can be very complex and patient may undergo so many investigations. So this is about paraneoplastic syndrome. There can be any kind of presentation, but a few of them are well described as characteristic classical syndromes. So encephalomyelitis, where brain as well as spine involved. Limbic encephalitis, where memory deficits, behavioral abnormalities, all those things can present with a subacute course. Then subacute cerebellar degeneration, otherwise called paraneoplastic cerebellar degeneration, obstruclonus myoclonus syndrome, subacute sensory neuronopathy, where patient will present with severe imbalance and abnormal movements, chronic intestinal pseudo obstruction, like I was telling, then Lambert-Eaton myasthenic syndrome and dermato. These are the classical syndromes. So when you see these syndromes, we can think that paraneoplastic has to be strongly considered, though non-paraneoplastic do exist. So this is a clue regarding how these syndromes can present. So when to think about paraneoplastic, somebody presenting with a neurologic syndrome with a strong history of smoking, history or family history of cancer, elderly. Then there is markers of systemic autoimmunity, subacute onset, multifocal involvement. Multifocal involvement means the same patient can have either cognitive involvement, then ataxia or Parkinsonism or neuropathy. Usually we look at one. If you carefully look, you will see that multiple things are involved. Then most important is neurologic syndromes of unexplained cause. Sometimes malignancy can be picked up later. Then other clues are there is an inflammatory CSF. Most of the time there will be only elevated protein. This we will treat as normal because the protein will be mildly elevated. 45 will be normal, if 46, 48, 50, 60 and all will say normal. Then OCB, oligoclonal bands in CSF. Some of the MRI pictures are written here. That is limbic encephalitis picture. Then brainstem encephalitis picture. Then there are a special picture for a paraneoplastic myelitis. And the other manifestations like paraneoplastic manifestation like ataxia, anorexia, fever, unexplained fever. So these are the clues towards a paraneoplastic syndrome. And this is autoimmune encephalitis is one of the commonest cause of encephalitis. It is more common than single virus in many studies. But often we think all these encephalitis either metabolic or viral. And if you ask, many a times virus will be negative and we'll just give acyclovir thinking that it's a viral encephalitis. And there is a proposed criteria, subacute onset less than 3 months with the memory deficit, altered mental status, psychiatric symptoms. So this can be the clinical presentation, and we should find a new CNS finding on examination, new onset seizures, CSF pleocytosis or MRI. Of these 4 things, at least one should be positive. So there is a clinical criteria, one laboratory criteria, and exclusion of other cause like virus, metabolic, all these things are very important in this. And that was a probable, that is the first step, and this is a definite diagnosis. So here again, same clinical symptoms, one radiological finding like limbic encephalitis, like picture should be there. Then inflammation in the CSF or EEG suggestive of the limbic encephalitis. Again, most important is that ruling out of other causes like secondary causes like systemic inflammatory or autoimmune diseases, infections. And if of the first three, if one is not met, if you get an antibody, which we are going to talk, which is well described is there, again you can call it as a limbic encephalitis. That is where the antibodies are also important. So just to get a flavor of how an autoimmune encephalitis present to us, this is a published case report, not ours. It's a 21-year-old lady presented with a hospital with confusion, agitation, auditory hallucination, suicidal ideation. She was febrile, but no focal deficits or meningeal signs. They thought it was a psychotic episode and discharged home. So in the Western country, they think it's a drug-related and all. But after discharge, symptoms progress. Psychiatric hospital admission was done. Patient had a hyperventilation. Later, patient became apneic, had seizures, then transferred to a tertiary care center. By this time, it is very clear it is not psychiatric because seizures have come. And brain CT and MRI are normal. CSF showed mildly elevated lymphocytes and protein. Again, this often people may say that normal or subtle abnormality. And again, the standard care which I was telling, viral encephalitis treatment was given. But patient developed again seizures, sensorium went down, intubated, transferred to ICU. There patient developed orofacial dyskinesias, involuntary movements of the extremities. So the EEG showed a non-convulsive status epilepticus, which is electrographic only. So anti-epileptics, general anesthesia was given. Again, serum and CSF. Again, this time CSF was done, and CSF showed an NMDA receptor antibodies. So now we got the diagnosis. It was an NMDA receptor encephalitis, and they found a ovarian cyst. This was an ovarian teratoma. Patient treated and improved. So this is the background of this kind of disease. I wanted everybody to see because sometimes you may come across somebody with the same disease going undiagnosed, because if there's no good neurological service, this can be missed and treated as psychiatric virus and all, which will require prolonged hospitalization. And early diagnosis and treatment will change the whole picture, which is happening now. So now we'll go to the topic proper, neuronal antibody evaluation, where and when. So this is the list of the neuronal antibodies. It's a big list. This was, I think, few years ago I wrote this review article. So ANA1, ANA2, ANA3, AGNA1, then CRIM5. So many antibodies are there. Purkinje cell, cytoplasmic antibodies. So the list is ever growing, and you can see so many cancers, so many syndromes. So it's very difficult to remember and practice that. And you can see from cerebral cortex all the way down. With the same syndrome, you can see so many other antibodies. So it is a little complex picture where it is not an equation like one antibody, one disease. So now comes where and how. So first we will do when to. So always it's not so easy. Always the disease, most of the time the disease will be very complex. But sometimes you will get a characteristic syndrome. I would like to call it as a signature. So though the manifestations are a variety, you can easily recognize some by signature, like either clinical or radiological. Just like sir was telling NMDS history, psychiatric symptoms, some orofacial dyskinesias, ventilator, dysautonomia. So if you see like that, you know it is an NMDA. We don't have to worry much. We can straight away look for a CSF NMDA. So this is Mahatma Gandhi signature, like that. That will be remembered. Limbic encephalitis, like memory, personality change, and characteristic MRI changes, subacute onset. We know it is not a virus, and then we can look for all the investigation concerned with limbic encephalitis. Paraneoplastic myelitis has got a characteristic radiological finding. And chorea in elderly, just like we say Sydenham's chorea in children. If an elderly smoker gets a chorea, most likely we should think it's a paraneoplastic due to CRIM5 antibody. Encephalomyelitis syndrome, where you will find brain as well as spine involvement. Again, encephalomyelitis we can think. NMDA we have already covered. Then the other one is a faciobrachial dystonic seizure. It will be just a brief movement of the hand and the face, which will look like some abnormal movement, but it will be an LGI1 antibody mediated. And neuromyelitis optica spectrum disorder, where spinal cord, brainstem syndromes. But it is related to aquaporin 4 antibody, but MOG antibody also can mimic, adding to the complexity. So this is the problem with diseases. So the above mentioned scenario is very clear indication that these are the situation where we should test for neuronal antibodies. But other cases it will be difficult. But where is the other situation is a multi-axial neurological involvement. So if you carefully examine, you will find that this patient has got a neuropathy also. But he would not have complained of that. But if you examine, you may see that. But he come with a memory impairment. Or he has got a cerebellar syndrome. That is what. But if you carefully see, you understood that his cognition also has gone. Or he has got a like a Parkinson-like, but careful examination show that there is significant involvement of the pyramidal system. So such cases, we know it could be autoimmune and it could be paraneoplastic. Now the risk factor approach, just like diabetes and hypertension, chest pain will be cardiac. Same approach is possible. All rheumatologists will be familiar, but we neurologists never had this approach. So if there is a history or personal history or family history of autoimmunity, then we should, when they come with a neurological syndrome, we have to keep in mind that again, just like a vascular risk factor. Most important is hypothyroidism, and we neurologists, I don't know about other people, I asked endocrinologists also, they also told that they never seriously consider hypothyroidism as an autoimmune disease, despite it's written in the books. So if you look at our EMRs and all, you will see that at a time 40-50% of our patients will be hypothyroidism and other. So it's a clue that we should think about hypothyroidism. This I learned when I went to Mayo. I was not dare enough to ask Dr. Vanda Lennon why you are thinking this is, because they speak as if this. When later I read that the hypothyroidism and Hashimoto thyroiditis was the first experimentally proven autoimmune disease, and the horror ototoxicosis was destroyed by Noel, Ross and Vitebsky based on their experiment. That is, one mouse, half thyroid they cut and injected in the same animal, and then animal was killed. They found that the Hashimoto's pattern is there. But in our regular practice, we don't give much importance to this. Second thing is malignancy. A lot of skin diseases are autoimmune. Then other thing is, if you get a myasthenia and other neurological, again, good thing that the disease could be. This is all statistics and risk only. Then stigmata of the autoimmune disease, again, examination, polyarthralgia, arthritis, deformity, rashes. So usually it may go unnoticed. Then other lab examination, elevated ESR, CRP, AG reversal, other markers like ANA, RA factor in a given neurological syndrome. It need not be always right, but if you have a clear explanation, like your patient has got a vitamin B12 deficiency, symptoms are matching, or there is a stroke, we don't have to give much importance to risk factor. But otherwise, you should think that this could be, and we should look from that angle. Now we are going into a clueless area. So where there is no history, stigmata, anything. But we should always suspect an autoimmune in etiology in all unexplained neurological syndrome. So, and we should go ahead testing for these antibodies. You may be surprised to see the results. So, how to send the sample? Which sample is to be tested? So, preferably we should test both serum and CSF. For example, in NMDA, CSF will be 100% positive. Serum will be about 89 to 93%. And for other antibodies, serum has a better yield. And in our experience, we found that sometimes CSF, we see a characteristic NMO, CSF, serum negative, then we go and test for CSF, it may become positive. So the main limitation in our country is the cost. So wherever possible, we should test both, though that there is no loop left. So if your lab is located far away, you should collect it and send the samples in a proper tubings, leak proof. Then it should, antibodies are stable up to 72 hours. So if it takes a longer time, it should be were packed in ice pack or cooling gel or dry ice, and should not send on weekends if there is an expected delay. So coming to the antibodies proper, they are classified in a different ways. One is paraneoplastic and non-paraneoplastic. Paraneoplastic means they are the markers of the malignancy. The body lodges an immune reaction against the malignancy, and that antibodies we are detecting. But some of these antibodies cross-react to the nervous system, so we get the disease. So if we get a paraneoplastic antibody positive in the right clinical context, it says that the syndrome is paraneoplastic. So usually the paraneoplastic syndromes are not antibody T cell mediated. The non-paraneoplastic are generally antibody mediated, cell surface antibody related, and they have a better prognosis, like NMDA, myasthenia antibody. If you filter this antibody, they may improve. So regarding the nomenclature, there is a lot of confusion about the names of the antibody. The first antibody was described in 1977. That was PCA-TR. PCA is Purkinje cell cytoplasmic antibody. TR was named after the trotter, who was the doctor. So that was only antibody named after the doctor. Rest all are by the patients. So YO for young, H for Hugh for Hull, Ma for Margaret. So these were named after the first patients from whom these antibodies were described. Subsequently, Dr. Vanda Lene, who was my mentor, she developed a nomenclature based on the immunofluorescence staining pattern. That is like if you see a neuronal nuclear staining pattern, it is called as ANA, anti-neuronal nuclear antibody. Then first described is 1, 2, 3 like that. It's against glial nuclear antibody AGNA, Purkinje cell cytoplasmic antibody PCA1. So, but later all the papers started coming with the target molecule. So when CRIM5 antibody was described, they described the target molecule. So the name is like this, amphiphysine NMDA receptor. Now all these are named like that. There's no confusion. So anti-Hu will be ANA1 in the second nomenclature, anti-Rai will be ANA2, anti-Yo will be PCA1. So method of testing, there are different methods. The traditional method is indirect immunofluorescence on animal tissue. So this was how the first antibody was described. So subsequently, so many other things have come up, like cell-based assays, ELISAs, but ELISA sometimes may not pick those cell surface antibodies. Now the standard practice followed in the major reference lab like Mayo and Oxford is indirect immunofluorescence. They use it as a first screening and then confirm it with other tests like Western blot or cell-based assay. We are also following similar techniques. This is the anti-neuronal nuclear antibody 1, 2 and 3 on a mouse brain. This is Purkinje cell cytoplasmic antibody. You can see the cytoplasmic staining nucleus is not stained. This is the Purkinje cell layer of the animal cerebellum. This is the molecular layer. This is the granular layer. This is the Purkinje cell cytoplasmic antibody. You can see Purkinje cells are staining and axons are stained. This is the molecular layer. This is the granular layer. And this was published long ago, probably I think 2001. And last year only the molecular target was described. This is the amphiphysine antibody staining. You can see molecular layer staining, granular layer staining, white matter staining. This is the CRIM5 antibody. So methods I already mentioned. This is the cell-based assay where this is LGA1 antibody. These are the transfected cells where they transfect the cells with LGA1, and when the antibody present you get a pattern. This is easy. But when you want to test so many antibodies, this will not work. And how to order the tests? Actually, doing the whole panel is the best method. This is what is practiced in Mayo. So they have the best results. For example, limbic encephalitis can be caused by Caspar-2, LGA1, ANA2 and many other antibodies. So if you just send Caspar or LGA1, that may come negative. And it has to be, sorry. So, and the interpretation of the results should be done very carefully. So that is where a neurologist is required. Like the Oxford and Mayo labs are run by neurologists. Barcelona lab is Because when you get a result, the person should be able to help the clinician to work on it. So even paraneoplastic antibodies can be seen in people with a cancer. The cancer sometimes can be very small. So if you see a paraneoplastic antibody, you should search for a cancer. You may come across an unrelated cancer, then you should treat that cancer and still keep searching for the cancer marked by the antibody. Sometimes panel may yield more than one antibody. So this will help you to search the cancer better. Suppose you get a CRIM5 positive along with acetylcholine receptor and anti-strational antibody, then you can look for thymoma. Otherwise, you'll have to look for many other things. So amphiphysine antibody in a woman could suggest a breast cancer. But if there is an ANA1 and CRIM5 positive, this could be a lung malignancy. Lambert-Eaton's only marker was PQ or N type of antibody. But if you get an AGNA along with that positive, then it is not a simple Lambert-Eaton. It's a paraneoplastic one. You should go for a paraneoplastic workup. So what is the value of antibody testing? Suppose you don't fulfill the full criteria, you know it's a partial syndrome. But if an antibody comes in with a positive result, we know we have to treat. So antibody interpretation is very important. That's why a clinician has a good role in that. Because antibody is a secondary evidence, unlike a pathology. So we know there is an immune reaction is going. If a CSF antibody is there, it's a better value than a serum antibody. And alternative diagnosis should always be considered because this is an antibody and a secondary evidence. Whether everything is falling in place. Suppose a paraneoplastic antibody was seen in a patient with a malignancy, but that encephalopathy could be metabolic also. So that is where everything we have to consider and play. A Casper2 antibody in a CSF has a propensity for encephalitis, but if you get in a serum alone, there is a peripheral nervous system like neuromyotonia presentation. Suppose you get a PCA1 antibody positive, you get a report that PCA1 positive in a male patient, you will have to cross check it because it's very rare in a male. Suppose it's a regular lab who test all tests, they will not go back and check whether it's a male. They take the report because I have come across a case like this. So then what to do with a negative test? A negative test never rule out the disease. Suppose only serum or CSF is tested, we should test the paired sample. If CSF was not tested, you would look for that. If serum only was tested, go for CSF or vice versa. Then if both are negative, if there is no alternate diagnosis, your suspicion is good. Because always your clinical judgment has a good value. That nobody should forget. That because it's an overall judgment rather than one. So if your suspicion is strong, you should do repeat testing after a later date. Sometimes the MOG and NMO can look alike, and if you send an NMO alone, it comes negative. That means it could be a MOG. So you should test properly. Right now MOG is not available in India. Again, you see a stiff person, you test only for GAD65, it could be due to amphiphysine or glycine antibody. Cerebellar ataxia, which you think PCA1 is positive but it is negative, but if you have tested for the full panel, you may come across a positive VGCC antibody. And negative test never ruling out a diagnosis. So NMDA can be diagnosed as a probable NMDA even if antibody is negative, but all other symptoms are there. So at the same time, if antibody is positive in a classical syndrome, you are finished. So you don't have to think much. Your work is over. And NMO spectrum diagnosis again can be made without antibody also, like seronegative NMO. And antibody only positive in 60 to 70% of paraneoplastic syndromes. But negative cases where antibody is negative, you can diagnose with the criteria. Where if you get a cancer and cancer removal improves the diagnosis, that is a definite paraneoplastic syndrome. So sometimes you will never get a cancer even on autopsy, but antibody will be positive. That means a very small focus, and that is eliminated by immunity. So where to test an antibody? So it is very evident. You should do in a very a dedicated setup where somebody trained to work on it. That helps you to improve the outcome, give you valuable suggestions. So conclusion is that it should be neuronal antibody testing should be done in all signature syndrome, but should be done in all unexplained neurological syndrome, multi-axial diseases, especially when there is a background history of autoimmunity. Preferably it should be done in a highly specialized center run by trained people. Thank you.
Thank you, Dr. Sudheeran. You made a difficult topic sound very simple. And before coming here, I was going through that Continuum journal, the last year, 2016, Neurology of Systemic Diseases, and there is a particular chapter on this. You said that if both serum and CSF are negative in a person who is strongly suspected to have such a type of a disorder, how later would you like to repeat these tests?
In Mayo, we say after 3 months.
3 months, I see.
But
Okay,
it's
fine.
not fixed, sir.
Fixed, okay.
You look for other causes.
Yes.
Still, I have an experience, I got a positive in after 2 weeks. Because patient was again becoming bad, so I didn't wait.
So generally around 3 months,
Yeah.
that's one thing.
3
And,
3 months, that's what we write.
Okay. And we have somebody who has done a thesis on NMO spectrum disorders. A patient with a conus cauda involvement and bilateral optic neuritis could be having an anti-MOG antibody positive NMO spectrum disorder. The other day I met Dr. Thomas Matthew, St. John's, and they are doing this anti-MOG antibody testing.
Oh, it started,
So
huh?
perhaps, yes, I think he started it after his recent visit to Kyoto.
Okay,
So perhaps that is an information. Anti-MOG antibodies are being done in Bangalore, St. John's. So
Okay.
if anybody wants
Also
to
we
utilize.
can send them.
Yeah. You can interact with Dr. Thomas
Yeah,
Matthew.
he is my friend.
Okay.
He
Then
told he
in-
is going to do.
Yes, we can encourage them by sending them samples. So this has been a very tough topic, and the audience, any questions?
Just to make it clear, that what is the protocol treatment other than the paraneoplastic syndromes? How exactly you would like to approach? In a sense, because since most of the audience are primary care physicians, etc. So would like to know that is there a sense for us to do these tests? What exactly the final outcome to the patient if he spends so much of money on these tests?
Outcome will be good, that's no
Yes.
doubt. Outcome
And,
will
and
be,
how is it managed further?
they will need a strong immunosuppression. Especially NMD are very difficult to manage in primary care because it will take a long drawn course. So that cases should be immediately sent to somewhere.
The reason why I raised was that because these tests, by investing on the test, you will be picking some of the patients which otherwise would have dumped as nothing more can be done.
Yeah.
See, I mean, that's where the point of
Yeah.
testing for this comes.
Yeah.
Sudheeran is talking on the antibody testing, how and where and how and when. So perhaps the treatment part of it would be, IVIG, plasma exchange and steroids and symptomatic management.
Yeah, cyclophosphamide, CellCept, all your treatment.
But Sudheeran, always when such a type of disease is there, we need protocols for management.
Yeah.
1, 2, 3 like that.
Yeah. How I do is I always use steroids because it's inexpensive. So when a second line is required, I go for IVIG. And long-term management will be either CellCept, Asaran, cyclophosphamide or methotrexate. Bad cases we go for rituximab. Case to case because it is.
I think the protocol for immunosuppressions are well developed in rheumatology,
Yeah.
which can be just
We
simply
just
imported
copy.
actually. Yes. Yes.
Yeah, so what you do is we copy from you people. We are daily interact with them.
I am 86 years old.
Yes, sir.
I have got some cerebellar symptoms.
Aha.
I have got some peripheral neuropathy.
Aha.
With steroid, B12 and some anticerebellar, I am feeling better.
Aha.
I have ruled out possibility of a cancer by tumor makers, and this is there from last 4 or 5 years. I am managing it. Can you give me any suggestion?
Yeah, I think you can go for CellCept. That's easy. CellCept has fewer side effects.
Yeah. Now, other thing is that is any other investigations are required for him, sir?
Any treatment?
That's what I'm saying, sir. Instead of steroid, you start on Cellcept and change, withdraw steroid after 3 months.
I don't take regularly.
Okay.
I get aggravated, I take for 4 or 5 days, then I stop.
Oh.
I am not on regular.
No,
I think,
But only anticerebral I take.
if it is a steroid responsive disease,
When I get activated, I take for 4 or 5 days, not more than 4 or 5 days. That too 10 milligrams.
oh,
I take only 10 milligrams. I am very stingy.
I treat 80-year-old people with their immunotherapy, but usually they can't walk, so there's no risk.
Late onset cerebral ataxia chronically going on.
Yeah.
Apparently negative family history.
Yeah.
First and a cost effective therapy would be genetic study. And then you go for other things. Dr. Chandrasekhar very aptly said, are there any tests to be done?
What I do is I do this neuronal antibody. So I have discovered so many newer antibodies. Based on that only that autoimmune atypical Parkinson's was discovered.
Thank you for the suggestion. Thank you very much.
Pardon?
Thank you for your good suggestion.
Okay, sir. Thank you, sir.
Any questions from the audience?
So as such, we feel this autoimmune disorders incidence is definitely increasing nowadays.
Yeah.
Do you blame the lifestyle for that? And if that's the reason, do our ancient things like your yoga, meditation, dhyana, do have that effect on the immune, especially on the brain, neurons, all those things?
I always feel so, but I don't have a proof. I always feel so.
Every day I get up at 4 o'clock. I do yoga for half an hour, meditation for half an hour, Sudarshan Kriya for half an hour. That gives me relief.
I think
I do it right. And I do little bit walking, not outside, on the terrace of my house. Definitely I found it. That has kept me fairly well. In spite of all, I am moving about, attending the
Thank you, Dr. Sudheeran. Thank
It
you
has
very
got-
much.
I spend about 2 hours every day, 4 o'clock morning to 6 o'clock.
great.
That has given me good relief.
That's great. I don't think we'll survive till that.
Thank you, Dr. Sudheeran. This was a very entertaining and very knowledge spreading kind of talk. Thank you.
Thanks.